purposely got them in the end of the day, so I got another client, spent a good hour, and I was surprised how much I got out, and the patient could hear the dead skin and keratin that you can see that I'm peeling away was also embedded against their eardrum. There were multiple layers of dead skin. So all this skin that I'm removing at the moment was once formerly lining the ear canal wall. But over time, this skin has died and it's replaced by another layer of skin underneath, and this skin then sheds. And in most of our ears, this skin naturally migrates out of the ear. We call it the epithelial migration. It's like the great wildebeest migration. And it's unique to the ear, whereby the skin, as it dies and sheds, it's got this ability to move sideways naturally out of the ear. And that's so the ear can cleanse itself of dead skin. If the ear didn't have that ability to self-cleanse itself, if that epithelial migration didn't take place, this is what will occur in every single human being on the planet. Everyone's ears will be full of dead skin, like this patient, and we need constant appointments to have this removed. So our ears have evolved over millennia for this natural migration to occur, but unfortunately this patient, for some reason, it stopped, and finding out the reasons is sometimes very difficult. Sometimes we just don't know why it stopped. This patient hasn't had any problems with their ears until recently now. The patient is an elderly patient, and as we age, the blood flow to the skin is naturally reduced, and especially on the posterior inferior aspect of the ear canal, which basically is the back bottom wall. That region is known to have reduced blood flow as we age, and when you've got reduced blood flow, the skin does migrate slower. Also, as we age, our ears produce less sebum and an oily sweat from the modified palpitoine glands, which are the sweat glands we find in our armpits. So without the sebum and this oily sweat, we don't have this natural oil which helps to moisturise and hydrate the layer of skin. So the skin that lines the ear canal, the moisture can rise to the surface without those oils and then evaporate. So basically, without the secretion of the sebum and the oily sweat, we generally develop dry skin. So two of these factors, when you've got dry skin, more friction, less blood flow, so natural reduced migration speeds of the dead skin of the ear, they can lead to a build of dead skin like this. But then you would have to ask yourself, why isn't every elderly patient suffering from this condition? So you can't purely put it down to that. Patients who undergo radiotherapy around the ears, radiotherapy can damage some of the glands in the dermis, again the sweat glands and the sebum, the sebaceous glands. So radiotherapy is also known to cause epithelial and keratinous build-up in the ear, so it's cause wearing hearing aids or wearing other sort of inserts and devices can push the wax further into the ear. So as we age, more patients wear hearing aids, and by wearing something in your ear, potentially it can halt the migration of the skin, so that's another reason. So there are multiple factors. Removing the dead skin can be quite difficult, as you can see. I've just put a bit of oil here just to help lubricate it, but it is really, really adhesive, this inner layer of skin. I'm really having to tug away at this to try and detach it and elevate it off the canal wall and eardrum. I'm using the fine end because when I was using the full zone suction code, there was a bit of clarinetting, and that's always a risk of dead skin. Clarinetting is when you perform microsuction with dead skin. The skin violently flaps at the tip of the sucker, and that emits a very loud, high-frequency squeal. It's not only loud for the patient, it's loud for myself, so I need to minimise that. In cases like this, you are invariably going to get a bit of clarinetting, but by using the fine end, you're going to reduce that. I'm also trying to take the opportunity to use the forceps when possible, and trying to pull the skin away, but even with the forceps, it's got a decent grip here, but it's still attached. Now later on, you will see me remove the whole layer of dead skin using the forceps, so eventually it does come away, but before I do that I have to just manipulate the skin a little bit more, get a better part of the skin that I can grip onto. At the moment is on the individual sheets of dead skin that the forceps have to grasp onto, so I need a bit more surface area. So you can see its skin by the texture, the consistency, it's almost translucent. You can see these little ripples, ribbons, texture on the skin. Skin is quite reflective, it contains a lot of keratin, so keratin is known to help to reflect harmful UV sun rays, so it has got this reflective quality, so the light that I'm shining with the endoscope and the periscope is reflecting the skin. The outer parts of the skin and the underskin, the underlayer is more white in appearance, transparent. The skin in the core, the centre is oxidised, so it's been there longer. So it's a darker shade. So again, there's key characteristics here that show us its skin. Now, I did ask the patient whether there had been poking near because its skin is right up against the drum, but they assured me that it didn't. So, and this is what can happen with dead skin. The dead skin starts to migrate off the eardrum. If it fails to do that, then it gives that appearance that this skin has been pushed in by the patient, but in fact they haven't, like this patient. It's just how this condition develops. Now, you could, if this skin wasn't removed today, eventually it's possible that it will form into a plug, and that plug can then lead to Keratinous obtrans. I talked a lot about Keratinous obtrans recently, and I've got a whole playlist, so if you want to learn more, please visit my YouTube channel, and under playlists, I've seen a lot of cases recently, but we're not at that stage where this patient's got Keratinous obtrans. Now, this dead skin, as it's dying and decaying, it can release lysosomal enzymes, which then release acidity, and that can then, acidity can cause ulceration of the underlying skin, which can then expose the bones, and you're always then at risk of potential canal fasciitis, which is quite very rare. So not just leaving the skin in the ear is not an option. We need to remove it. Nothing apart from the hearing may bad come out of it, but potentially it can. So we just don't know, so it's important that we clean it if we can. You can see I've got a good surface area, got the forceps in, peeled that away. Now there's still skin still left on the eardrum, anteriorly. It's only a thin sheet, but we want to remove that if possible. It is obviously tricky. The patient did suffer from the caloric effect. As we vacuum the ear, it reduces the ear temperature. Each ear has an organ of balance. We call it the vestibular system. There's 3 semicircular canals, and they are affected by pressure and temperature. If you're sat still, like this patient is, the patient's receiving equal messages from each organ of balance to their brain, so the brain knows that the patient is stationary, sat still. But when you vacuum the ear, it reduces the ear temperature, and when we reduce the ear temperature, it inhibits the performance of the organ of balance in this ear. So this ear is sending less signals to the brain, so the brain's receiving more signals from their right ear, and it tricks the brain into thinking that you're moving to the left side. Our eyes try to correct our ears, and we then experience vertigo, feeling the room spinning around and spinning around the room. Some patients become a bit nauseous, even physically sick, and this patient did suffer from the caloric effect. They did suffer from some vertigo. It was short lasting, and it's always the case when you're removing stuff near the eardrum, because that's where the temperature or even the pressure, as we're pulling the skin, the eardrum could be flexing laterally towards the entrance, which can create negative pressure in the middle ear, because the middle ear cavity is increased, so there's less air pressure as a result, and that can also set off the organ of balance. But within a few minutes the patient's fine. Just another aliquot of olive oil spray just to soften the skin a little bit more. Just hovering over, and we get the edge of the skin again. So you've got a fantastic view. We're really up close and personal with this patient's eardrum. Really see what we're doing. Just trying to release some of the excess oil now. Again, I'm just searching for this where to suction the skin. I haven't found the best position. Peeling upwards and slowly coming skin on the eardrum had settled like layers of onions. So I was explaining it to the patient and their son, and the son had a fantastic view. They were looking over my right shoulder and they could see everything I was doing. And it was just like layers of skin, almost like an onion, and we're trying to peel away each layer. I've had another interesting week this week. I've had many children, and it's beginning to concern me actually. NHS services in the UK are really struggling, especially in ENT. In the waiting list, one of the patients I had today is 2.5 years. The child had perforation, really bad wax build-up in one ear, and the other ear has still got glue, still waiting for an ENT appointment. The speech and language has been affected. Now, it's not ENT's fault. They've got this waiting list and they're planning to do it, and I've got friends who are consultants in the NHS, and they are working their socks off trying to get this waiting list down, but there's so many people on the waiting list, and with children in particular, like with this child I met, I could tell that they were really struggling to hear when they came, and it had affected their speech and language, and it's something that I did discuss with the patient as well. Unfortunately, it was a bit of a tricky procedure. That wax would have been that way for so long, it was rock solid, and because they were told that they had a perforation that day before, they were told not to use drops. The children, I generally like them to use drops within a couple of days, and the patient was still blessed. It's like 24 years of age, and I had to get both parents in, and trying their best to hold the patient, and they just really wanted me to remove it. We accidentally, I don't know if I caught the ear or as the wax was coming away, I had to use a hook, and it was such a hard piece of wax. The side bit was quite rough, and I don't know if it was myself or the wax plug. It grazed the entrance of the ridge. It was bleeding a little bit, bless her. We stemmed that, it wasn't a problem, but that wax has got so bad because obviously they can't use drops because they're told about perforation. It's made it a really difficult case. There's just no way, at the stage where we're at with that patient, that they're going to allow that wax to be removed under normal circumstances. They're going to have to undergo a general anaesthetic, there's no doubt about it. They do have glue in the right side now. They just can't really wait for ENT any longer. Unfortunately, they have recently got some medical private cover, and I think in the UK that's what's happening. Is there's a two-tier system. We've got NHS services, and we've got private, and a lot of people are using private healthcare now, but not everyone is going to be in a position where they can access that. And especially for children, it's really it's kind of sad to see, because you can see how it's affecting this child's development, not able to hear, to not seeing a consultant for a proper diagnosis, treatment. So hopefully we're going to help her with the glue ear. I've given some advice, and we just don't know what's going on the left ear behind the wax. There's a bit of perforation. There's also got glue ear there. We just don't know how to know until we get the wax out, but we're going to have to do a GA to have that wax removed, I suspect. So another child today. Sorry, as you're watching, I'm just peeling away skin, so continue to watch that. I don't need to explain the exact technique, because it's self-explanatory, but another child I saw today, saw her a week ago. She had grade 1/2 Keratinous obstruction on the left ear, and her ear canal was so narrow at the entrance, and the median bit was blocked, and they've been waiting to see ENT. They did see ENT eventually, and they go back annually, but again, it needs to be every 6 months for that condition. It's one of the most extreme cases I've performed. I got some of it out last time, but the ear canal kept collapsing, it was swollen, just couldn't get the instruments in the ear. But they could hear a lot better after last time, but I got them back in today, and parents got them in the end of the day, so I got no other clients. Spent a good hour, and I was surprised how much I got out, and the patient